Hi everybody, this is Tom, and in this video I'm going to be going through all of cardiology. This is the fundamental stuff that you need to know about cardiology. This video is going to be quite long, obviously, and it's going to involve a question and answer format. So I'm going to be asking you a question. I want you to write down the answer if you want to get the most out of this video, commit the answer to paper. Then I'll go through the answer with an explanation. So, for example, let's do a kind of practice run. What is the term for the percentage of blood that the left ventricle pumps out with each heartbeat? So at this point, write down on a piece of paper your answer to this question. And the answer is ejection fraction. So the purpose of this video is to learn directly from the video. To get the most out of it, answer the questions, really think and engage your brain, try and come up with the answers, then we'll go through them. Don't take notes from this video. I've already created a perfect set of notes exactly on all of this content with a question and answer format and all the content you need in there, illustrations and everything. And you can download those using the link in the description below. In order to download those, you do need to be a member of the Zero to Finals Patreon, but that gives you access to the Zero to Finals member site where you get flashcards, you get short answer questions, multiple choice questions, extended matching questions, access to the Fact Trainer tool, which is like Anki, but you don't have to create your own flashcards on there, and the revision tracker tool, so you can perfectly prepare for exams and be ready on the exam day. So save yourself time and energy, sign up to the Zero to Finals Patreon, get access to this full set of notes, and access to all the questions and everything else. But for now, let's get straight into this video. So we're going to start with some basic anatomy of the heart. So this first big blood vessel, this is question 1. What is the name of this big blood vessel here? These are the pulmonary arteries. What is the name of this vessel? That's the superior vena cava. Question 3. What is the name of this space on the top right-hand side of the heart? This is the right atrium. And question 4, what is the name of this valve here? It's the pulmonary valve leading into the pulmonary arteries. Question 5, what's the name of this valve between the right atrium and this bottom chamber? This is the tricuspid valve. Question 6. What's the name of this blood vessel going into the heart? This is the inferior vena cava. Question 7. What's the name of this chamber at the bottom right-hand side of the heart? This is the right ventricle. Question 8. What's the name of this big blood vessel coming out of the heart? This is the aorta, which is what pumps blood around the body. Question 9. What is the name of the vessels that bring blood into the heart on the left-hand side? These are the pulmonary veins coming back and draining blood away from the lungs, taking them into the heart. Question 10. What's the name of this chamber or this space on the top left-hand side of the heart? This is the left atrium. Question 11. what's the name of this valve? This is the aortic valve. Question 12. What's the name of this valve coming from the left atrium into the bottom chamber? This is called the mitral valve. And finally, what's the name of this bottom left chamber in the heart? This is the left ventricle. Now let's have a look at some anatomy on the outside of the heart. So question 14 would be, what is this middle branch coming off the aorta? This is the left common carotid artery. Question 15. What is the name of this first branch? This is the brachiocephalic artery. Question 16. What's this big blood vessel coming out of the heart? The aorta. Question 17. What's the name of this artery which supplies blood to the heart muscle? This is the right coronary artery. Question 18. What's the name of this third branch off the aorta? This is the left subclavian artery. Question 19. What is the name of this blood vessel? This is the left coronary artery. Question 20. What is the name of this branch of the left coronary artery that's going round the side and the back of the heart? The circumflex artery. Question 21. What's the name of this big vessel that's a branch of the left coronary artery going down the front of the heart? This is the left anterior descending artery. Okay, on to a case. So the first case is a 56-year-old man who presents to his GP, and he's worried about his risk of cardiovascular disease, mainly because his father died of a myocardial infarction when he was 58, so 2 years older than he is. And he's had some blood results back, and his cholesterol is 6.7, and the normal cholesterol is less than 5. So question 1 for this case is, what disease process causes cardiovascular disease? Atherosclerosis. And atheromas are fatty deposits, and sclerosis refers to hardening or stiffening of the artery. And you can see here inside the artery is this yellow plaque, which is called an atherosclerotic plaque. And this is what causes narrowing of the artery and stiffening of the walls. Question 2. What scoring system is used to calculate somebody's risk of cardiovascular disease? The Q-RISK-3 score. And this calculates the percentage risk of a myocardial infarction or a heart attack or a stroke in the next 10 years as a percentage. Question 3. What threshold would be used for when you would offer somebody drug treatment to reduce their risk of cardiovascular disease? When the Q-risk-3 score is above 10%. Although the NICE guidelines say don't rule out offering them statins if they're below 10%, if their risk is going to be disproportionately high. For example, they have a really high cholesterol, a strong family history, and so on. Question 4. When would you offer statins or drug treatment to reduce their risk without calculating the Q-risk-3 score? There's two groups of patients where you don't need to calculate the Q-risk-3 score, you just give them statins. That is patients with chronic kidney disease and patients with type 1 diabetes who've had the condition for more than 10 years or they're older than 40. And the fifth and final question for this case is, what is the initial drug treatment that you would offer? Sorry, just the fifth question. Atorvastatin 20 milligrams, which you take at night time. Question 6, which is the final question for this case. What follow-up monitoring would you arrange after you give them statins and you start statins? They need their liver function tests and their lipids, so measuring their cholesterol, HDL, LDL, and so on, at 3 months after starting. The liver function tests because statins can cause a rise in the ALT and the AST, and generally you continue the statins if it's less than 3 times the upper limit of normal. And you would check the lipids because you're aiming for more than a 40% reduction in the non-HDL cholesterol. So HDL cholesterol is kind of the good cholesterol. You want a 40% reduction in the non-HDL cholesterol. So if you don't achieve that, you would increase the dose of the statins. Okay, on to the second case. This is a 74-year-old woman, again presenting to the GP. She has recurrent chest pain and tightness and a pressure in her chest on exertion, never at rest. The pain settles within 5 to 10 minutes of resting. Question 1. What is your suspected diagnosis? The answer is stable angina. So she gets pain on exertion, never at rest, and it settles with rest. Question 2. What's the basic pathophysiology behind stable angina? So you have this heart, and you've got the coronary arteries, which take blood to the heart muscle. In stable angina, there's atherosclerosis and narrowing of those coronary arteries, which reduces how much blood can get to the myocardium or the heart muscle. And so during exercise, the demands of the heart can't be met with blood supply due to this restricted blood flow. Question 3. What treatment can be given to give immediate symptomatic relief? So she has some chest pain during exertion, she takes a treatment and she gets immediate relief. What treatment is that? The treatment is sublingual, meaning under the tongue, glyceryl trinitrate, or GTN. So this is a spray under the tongue. It's got nitrates in it, which causes vasodilation. So it opens up the blood vessels. So the idea is it expands the coronary arteries allowing more blood to get through. However, there's some side effects because you don't just expand the coronary arteries, you expand other blood vessels as well, so it can often cause headaches and dizziness. Question 4. What options are there? What are the first-line options for longer-term symptomatic relief? So there's two options. One is beta blockers, for example, bisoprolol, and the second is calcium channel blockers, not just any calcium channel blockers, specifically diltiazem or verapamil. However, you would avoid calcium channel blockers in patients who have heart failure with reduced ejection fraction. So generally, patients end up on beta blockers as the first line. And question 5, what are the surgical treatment options for this patient's condition? So there are two procedural and surgical options. The first is percutaneous coronary intervention, or PCI. So what this involves doing is inserting a catheter via the femoral or the brachial artery, so the femoral artery in the groin or the brachial artery in the wrist, and then feeding this up to, or the brachial artery in the arm, feeding this catheter up to the coronary arteries, and then under X-ray guidance, feeding the catheter into the affected coronary artery and using a balloon to expand and stretch the coronary artery where it's stenosed, and then inserting a stent into the coronary artery to keep it open. So stretching it and expanding it is called angioplasty, and then putting a stent in is called stenting. The second procedural or surgical option is a coronary artery bypass graft, or CABG. This involves making a big cut down the middle of the chest, which is a midline stenotomy incision, so they'll have a big scar here. The second thing is using a graft vessel, so taking a blood vessel from somewhere else in the body and using it to bypass the coronary arteries. So that vessel could be the saphenous vein from the inside of the leg, the radial artery from the wrist, and then attaching those from the aorta, bypassing the narrowed coronary artery. Or you can take the internal thoracic artery, which comes off the subclavian artery, and just repositioning the end of it past the coronary artery that's blocked. So they're your options, PCI and CABG. Let's move on to the next case. Next case is a 64-year-old man who presents with severe crushing chest pain, which is lasting for minutes. It radiates to his left arm and to his jaw, and he's sweaty and clammy. So the first question is, what's the suspected diagnosis in this case? The diagnosis which we're suspecting is acute coronary syndrome, or a heart attack or myocardial infarction. So you can see here, this is where the coronary artery is blocked and it stops blood flowing to a section of the heart, causing ischemia or a lack of oxygen to that section of the heart, to the muscle, and infarction, which is damage to the muscle tissue. Question 2. If you see this patient, he comes in to see you, what's the initial investigation? The very first investigation you do? The first investigation is an ECG. Question 3. What are the types of acute coronary syndrome? There's 3 types. The first type is unstable angina, and this is where you have symptoms of acute coronary syndrome, so chest pain at rest. But when you do the ECG, there's no ST elevation, there's no new left bundle branch block, and when you check the troponin blood test, it's normal. The second type of acute coronary syndrome is an ST elevation myocardial infarction, or a STEMI. And this is when this patient presents with chest pain at rest, and you do an ECG, and you diagnose this by there being an ST elevation. So ST segment on the ECG will be elevated, or if they have new left bundle branch block on the ECG. And the third type of acute coronary syndrome is a non-ST elevation myocardial infarction. And this is diagnosed when there's no ST elevation or new left bundle branch block on the ECG, but there's a raised troponin blood test result. So question 4, what drugs are you going to start immediately during assessment and transfer to hospital? The first thing is aspirin 300 milligrams, intravenous morphine for pain, intravenous antiemetic for nausea, for example, metoclopramide, and a nitrate, for example, GTN spray. And the fifth and final question on this one, what blood test is used to diagnose an NSTEMI? A troponin blood test. So just to go through, what investigations would you do to make a diagnosis in a patient presenting with chest pain? First thing you do is an ECG. If they have ST elevation or new left bundle branch block, you can diagnose a STEMI. If there's no ST elevation or left bundle branch block, next thing you do is perform a troponin blood test. If the troponin is positive, you can diagnose an NSTEMI. If the troponin is negative, then it's likely unstable angina or not a heart condition, so a non-cardiac cause of chest pain. Okay, let's move on to the next case, which is a 45-year-old man. He presents with sharp central chest pain. And this chest pain is worse when he's lying down on his back, and it's better when he's sitting forwards. And he has a low-grade fever. So question 1, what is the suspected diagnosis? The suspected diagnosis is pericarditis, which is inflammation of the pericardium. The pericardium is the membrane that surrounds the heart. Question 2. What is the key examination finding on auscultation? So you listen to his heart with your stethoscope. What's the key thing that you'll hear? A friction rub. This is a rubbing or a scratching sound that happens alongside the heart sounds. So you can imagine that inflamed pericardium, as the heart's beating, it's rubbing and causing this scratching sound. Question 3. What's the first line initial treatment for this condition? Non-steroidal anti-inflammatory drugs, for example, aspirin or ibuprofen. And the aim is to reduce inflammation. Question 4. What are the common ECG findings in this condition? 2 findings. There's saddle-shaped ST elevation. So it looks like a saddle or a kind of U shape to the ST segment, and it's elevated. And the second one is PR depression. So the PR segment is dropped. And the fifth and final question for this case is, what complication of this condition can cause decreased cardiac output? A cardiac tamponade, which is also known as a pericardial tamponade. So as you can see here, there's a pericardial effusion, which means fluid building up inside the pericardial cavity. And this fluid builds up to the point where it actually squashes and causes compression of the heart. So this means that the heart can't pump out and fill up with enough blood. And so you get a reduced cardiac output. And this is a medical emergency, and it requires rapid drainage of this fluid. So if you're enjoying this video, hopefully you are, consider signing up to the Zero to Finals Ultimate Revision course, which is the perfect course if you're going to be sitting finals or you're thinking about sitting finals in the next year or so. I've got courses coming up in October, November, December, and it's a full day of revision, very similar to this, but with more jokes and more memes and more fun, and it's very interactive. And the idea is to really learn the key content. So you've got all the content that you could learn, and the course aims to cover the kind of 20% of the content that you could learn, which is going to account for 80% of what comes up on the exams. You also get the Ultimate Revision course book, which aims to cover everything you need for finals, all the key stuff, and 160 flashcards that you can take away and keep rapidly testing yourself with. So here's what someone who attended the course in January, she emailed me to say she'd done really well. She said, I wanted to email to let you know how I got on with the MLA after using your revision course materials with a sprinkle of PassMed. I would say if she used the Zero to Finals member site, she may have done even better. But she said, I'm proud to announce I got 81.5%, which is 1.5% off the distinction mark set by my university. So she did extremely well. I also found out I got the second highest mark in my year group, which is crazy. So I've been spreading the word to my friends in the lower years because this course was an absolute game changer. So if you want to attend the course, there'll be a link in the description, or you can head to zerotofinals.com/medicalschoolfinals for that course. Okay, so on to the next case. The next case is a 70-year-old woman who presents acutely short of breath, and she has frothy pink sputum with her cough. She's tachypneic, meaning she has a raised respiratory rate, and she has bibasal crackles on her chest when you auscultate her lungs. She has a history of myocardial infarction and hypertension. So, first question is, what's your suspected diagnosis? The suspected diagnosis is acute left ventricular failure. So the left side of her heart has acutely failed to keep up with the demand, and pulmonary edema. So this is where there's failure of the left ventricle to move blood into the systemic circulation adequately, and the back pressure from the left ventricle to the left atrium and then to the lungs causes fluid to leak into the lung tissue, causing pulmonary edema, which causes her shortness of breath and feeling unwell. Question 2. What position makes her shortness of breath worse? Her shortness of breath will be worse when she's lying flat. So if you imagine the fluid will sink to the bottom with gravity, if she's lying flat, the fluid will affect a greater surface area of her lungs. And if she's sitting up or standing up, it will only affect a smaller area. Question 3. What's the immediate management if you're in hospital? So you get called to see this patient, you're the junior doctor on the ward, you suspect this diagnosis, what's your immediate management? I use the sodium mnemonic to remember this. S for sit the patient up. Remember, being upright is going to be better. O for oxygen. D for diuretics, for example, intravenous furosemide to clear that fluid from the lungs. I for IV fluids stopped. So this may be caused by somebody giving too much IV fluids to this patient. So you need to stop those IV fluids. U for underlying cause treated. So look for the underlying cause, whether she's had maybe another heart attack, or she's got some infection, or something else is causing this. You need to stop and treat that underlying cause. And the final one is monitor fluid balance. So put the patient on a fluid balance chart so you can monitor how much fluid is going in and out. Question 4 is what investigation would be used to assess for arrhythmias or ischemia to the heart? An ECG. So if you see this patient, do an ECG, just make sure they're not having a new myocardial infarction, or they've got no problem with an arrhythmia like fast atrial fibrillation or something. Question 5. What appearance of the heart will be seen on a chest X-ray in this patient? Cardiomegaly, or a big heart. And you can assess this by the cardiothoracic ratio. And if it's more than 0.5, that suggests cardiomegaly. And the way to assess this is you take the widest part of the heart and you take the diameter of the lung fields. And if the widest part of the heart is more than half the diameter of the lung fields, that's cardiomegaly. Okay, on to the next question, or the next case. The next case is a 62-year-old man who presents to his GP with breathlessness on exertion and swollen ankles. This has been going on for a little while now, and he reports waking up at night gasping for breath. And he has a history of a myocardial infarction. Question 1. What's your suspected diagnosis? Heart failure. And this is caused by impaired function of the left ventricle not being able to send enough blood out of the heart and round the body. So there's a reduced ejection fraction and a reduced cardiac output. This causes back pressure, and the back pressure goes first into the lungs, causing pulmonary edema, and then through the right side of the heart to the systemic venous system and causes peripheral edema. Question 2. What are the key symptoms when this patient lies flat? What's the key symptom? The key symptom is orthopnea, and this refers to breathlessness when lying flat, which is relieved by sitting or standing. It basically is caused by the fluid settling with gravity over a greater surface area of the lungs when lying flat compared to being upright. Question 3. What's the initial diagnostic blood test for this condition? The blood test is an N-terminal pro-B-type natriuretic peptide, or NT-proBNP. This is released when the heart muscle is stretched and overloaded, and it's elevated in heart failure. If the result is 400 to 2,000 nanograms per litre, the patient should be seen and have an echocardiogram within 6 weeks. And if it's above 2,000, they should be seen and have an echocardiogram within 2 weeks. That's what the guidelines say. So question 4, what is the first-line imaging investigation? I already gave you a hint. It's an echocardiogram, which assesses the ejection fraction, which is what percentage of the blood inside the left ventricle is pumped out with each beat, and the heart function. Question 5. What's the first-line medical treatment for heart failure? There's 4 drugs. I use the ABAL mnemonic, ABAL. A is for ACE inhibitor, for example, ramipril, and this is titrated up to the highest dose that's tolerated. B is for beta blocker, for example, bisoprolol, again titrated up as high as can go. The next A is for an aldosterone antagonist, and this is, for example, spironolactone or eplerenone, if this is needed. And the final L is for a loop diuretic, for example, furosemide or bumetanide, which is to treat the symptoms of edema, so extra fluid in the ankles or affecting the lungs. On to the next case. A 55-year-old woman has a clinic blood pressure reading, so she's seen by a GP. Blood pressure is 150/95, so a bit high. She does home readings over the course of a week, and the average is 140/88 millimeters of mercury. She has no other medical conditions. Question 1. What is the diagnosis? She has hypertension or high blood pressure, and this is defined as a clinic blood pressure reading above 140/90 or home or ambulatory readings above 135/85. So if someone has a one-off reading in the clinic, say seeing the GP or the nurse or the pharmacist, it's recommended to do home readings or ambulatory readings to get a confirmed result and make sure it's not just a one-off or a condition called white coat syndrome, where the blood pressure goes up when you see a doctor. Question 2. What blood pressure measurement frequency is recommended for screening for hypertension in otherwise healthy individuals? So how often would you check the blood pressure in somebody who's healthy? Every 5 years. So the NICE guidelines recommend screening for hypertension every 5 years in healthy individuals. You do it more often if the blood pressure is borderline, and it's recommended yearly in patients who have type 2 diabetes. Question 3. What's the first-line treatment for patients over the age of 55? So after you address lifestyle factors like salt intake, exercise, diet, and so on, the first-line treatment, if they're over 55, is calcium channel blockers, for example, amlodipine. Question 4. What's the first-line treatment for patients under the age of 55? First line, if they're under 55, is ACE inhibitors, for example, ramipril, except if they're Black African or African Caribbean family origin, then the recommendation is for calcium channel blockers. Question 5. What's the key common side effect to calcium channel blockers? Ankle edema. So swelling of the ankles is common with calcium channel blockers. And question 6, what's the common side effect of ACE inhibitors? The key common side effect to warn people about. A dry cough. So if you're going to remember 2 side effects, calcium channel blockers cause ankle swelling and ACE inhibitors cause a dry cough. On to the next case. Next case is a 65-year-old man who presents with dizziness on exertion. So he finds, say, walking up a hill, he starts to feel a bit dizzy. When you examine him, he has an ejection systolic murmur, which is heard loudest in the aortic area of the chest. And the murmur can also be heard when auscultating the carotids. Question 1. What's the suspected diagnosis? Aortic stenosis. So this is where there's narrowing of the aortic valve, and this causes an ejection systolic murmur. So when the left ventricle is pumping blood through that narrowed aortic valve, that turbulence as it goes through causes a murmur during systolic contraction. Question 2. What are the causes of the normal first and second heart sounds? So if you listen to a normal healthy patient, you'll get this lub-dub, lub-dub, lub-dub. These 2 first and second heart sounds. The first one is S1, the second one is S2. The first heart sound comes from closure of the atrioventricular valves. So this is the mitral and the tricuspid valve. And it happens at the start of systolic contraction of the ventricles. So imagine the ventricles are pumping blood through the pulmonary and aortic valves. And in order to prevent it from going back into the right and left atrium, the tricuspid and mitral valves shut, and that causes that first lub, that S1 sound. S2, or the second heart sound, is caused by closure of the semilunar valves. So this is the pulmonary and aortic valves. And this is once the systolic contraction of the heart is complete, so once the ventricles have stopped contracting, the aortic and pulmonary valves close to prevent blood flowing back into the ventricles from the pulmonary arteries and the aorta. And this causes that second heart sound, the dub. So you've got lub-dub, lub-dub. Question 3. What's the most common cause of aortic stenosis? The most common cause is idiopathic age-related calcification. So essentially the person is getting old and their aortic valve is getting old and it's calcified and sort of hardened and narrowed. Question 4. What peripheral examination findings might you see in a patient with aortic stenosis? Firstly, a slow rising pulse. So when you palpate the pulse, instead of kind of coming up like this, really hard against your fingers, it comes up slowly. And this is due to the restricted flow through the aortic valve, which reduces the rate of expansion of the pulse. The second thing is called a narrow pulse pressure, which refers to a small difference between the systolic and the diastolic blood pressure. So, for example, the systolic blood pressure might be 110 and the diastolic pressure might be 100. Like the gap between those numbers is smaller. Question 5. What effect does aortic stenosis have on the heart long term? What will happen to the heart? There will be left ventricular hypertrophy. So essentially, the left ventricle is working harder to squeeze blood through that narrow valve. It's undergoing some extra strain, and so the muscle of the left ventricle becomes thickened and larger. And this is left ventricular hypertrophy. Okay, on to the next case. Next case is a 57-year-old man with a midline sternotomy scar, so a big scar down the center of his chest. And when you listen to his heart sounds, a metallic click replaces S1, or the first heart sound. Question 1. What are the most common indications for heart valve replacement? The two most common indications are aortic stenosis, which is the most common, and mitral regurgitation, which is the second most common. Question 2. In this case, where the metallic click is replacing S1, what is the valve replacement here? This patient has a mechanical or metal mitral valve. And if you have a metallic mitral valve, the metallic click will replace S1 if it's a mechanical mitral valve. So the first heart sound, remember, is usually closure of the mitral valve, and so the metallic click will replace that. And a metallic click will replace S2, or the second heart sound, if there's a mechanical aortic valve. If the patient has a bioprosthetic valve from a pig or a cow, and it's made of actual tissue rather than metal, these replacement valves don't cause a metallic click. Question 3. What type of valve will require warfarin long term? Mechanical or metallic valves. So if a patient has a mechanical valve, they need lifelong anticoagulation to thin their blood with warfarin. And this is due to the risk of thrombus formation, so forming blood clots around that metal valve. The target INR for the warfarin is 2.5 to 3.5, which is higher than atrial fibrillation, which is 2 to 3. Bioprosthetic valves don't require anticoagulation with warfarin. Question 4. What key infective complication is possible with valve replacement surgery? What's the key important one? Infective endocarditis. So this is infection around where the valve has been replaced. Next question, or next case. A 40-year-old woman with a history of mitral valve disease presents with a fever and fatigue. Examination of her reveals a new heart murmur. Question 1. What's the suspected diagnosis? Infective endocarditis, which is infection of the heart endothelium, or the inner surface of the heart, often affecting the valves. Question 2. What's the most common causative organism? Most commonly, it's caused by a bacteria called Staphylococcus aureus, which is the most common cause of loads of conditions. Question 3. What's the key diagnostic investigations for diagnosing infective endocarditis? So firstly, you're going to perform blood cultures, specifically 3 blood cultures separated by 6 hours, taken from different sites of the body. And the second investigation is a transesophageal echocardiogram. So actually putting the probe down into the esophagus and taking an echocardiogram from there to get a perfect picture of the heart. Question 4. What are the top 2 key risk factors for infective endocarditis? The first is structural heart disease, particularly valve pathology, for example, mitral valve prolapse or regurgitation. The second one is intravenous drug use. So if you imagine somebody injecting intravenous drugs with a needle that's potentially dirty and then introducing bacteria into the venous system, that then travels to the heart and causes infective endocarditis. Question 5. What examination findings would you look for in this patient's hands to indicate infectious endocarditis? So the first is splinter hemorrhages, which are thin red-brown lines that you can see on the fingernails. The second is Osler's nodes, and these are tender red-purple nodules, so they're actually raised and you can feel a little bump under the skin on the pads of the fingers and the toes. The third one is Janeway lesions, and these are painless red flat macules. So they're flat, but you can see red sort of circles, and these tend to affect the palms of the hands and the soles of the feet. And the final one, if it's been there for a while, the infectious endocarditis, it can cause finger clubbing. On to the next case. The next case is a 30-year-old man, and he presents with exertional dizziness. So when he's exercising or doing something strenuous, he becomes dizzy. And he has a family history of sudden cardiac death. So somebody or multiple people in his family died suddenly of a heart problem. And when you examine him, he has a murmur at the lower left sternal border. Question 1. What's your suspected diagnosis? The suspected diagnosis is hypertrophic obstructive cardiomyopathy. Cardio refers to the heart, myo refers to the muscle, and pathy refers to disorder or disease. And in HOCM, or hypertrophic obstructive cardiomyopathy, the left ventricle muscle becomes thickened, and the septum thickens, and it kind of bulges into the left ventricle. And the problem here is it causes obstruction to the outflow of blood. Specifically, this is called left ventricular outflow tract obstruction. Question 2. What is the inheritance pattern of this condition? It's an autosomal dominant condition. It's caused by a mutation or a gene defect which codes for the sarcomere protein, and it affects about 1 in 500 people. So it's relatively common. Question 3. What's the key diagnostic test? The first line test you're going to do on this patient. An echocardiogram. So this confirms the left ventricular hypertrophy and outflow tract obstruction. You'll probably go on to have then genetic tests as well. Question 4. What's the first line medical treatment? So you're going to give this patient a medication to help his symptoms and reduce the risk of complications. Beta blockers, for example, bisoprolol, and these reduce the heart rate and improve the outflow obstruction from the heart. Question 5. What's the surgical treatment for this condition? Surgical myectomy, which involves removing part of the heart septum to relieve the obstruction to outflow of blood from the heart. I hope you're enjoying this video. Do let me know in the comments if you like this video, you like this format, and you want to see more of this type of content. So I'm planning to cover all the topics eventually, so cardiology, respiratory, endocrinology, gastroenterology, even obstetrics, pediatrics, and everything, although that's going to take a lot of time. But I'm going to cover it, each topic, with 3 videos. So there'll be a cardiology fundamentals video, then there'll be a cardiology core content video, and then a cardiology advanced video. So each one covers the whole of cardiology, but just at kind of different levels. So the fundamentals, this is the stuff everybody should know. The core content, this is the stuff that the good students will know. And then the advanced content is the stuff that the top students will know. So I'll be posting the version of cardiology, the other cardiology video soon. The advanced videos will be available on Patreon. So they'll be for Patreon members only. But if you get the Patreon membership, you get access to the notes. So hopefully you're not making notes from this video. You're just going to download them from Patreon, ready-made, so you can go and review them as many times as you like as a PDF. But you also get early access to the videos, you get, of course, the notes, and then you get access to the Zero to Finals member site with all the questions and everything else on there. So do sign up to the Patreon, leave me a comment to let me know if you like these type of videos, and I will be making more of them. But for now, let's move on to more of the electrical side of the heart. So we've been doing lots of structural stuff for the heart. Now let's move on to the electrical side. So ECGs, arrhythmias, and everything. And we need to start with some basic anatomy again. So firstly, question 1, what is this piece of the electrical signal in the heart? What's this called? This is the pacemaker of the heart where all the electrical signals start. This is the sinoatrial node. Question 2. What is the name of this structure which helps electrical signals pass from the atria to the ventricles? This is the atrioventricular node. Question 3. What is the name of this sort of electrical wiring that takes the signals to the right ventricle? This is the right bundle. Question 4. What is the name of this kind of wiring that takes signals across to the left atrium? This is called Bachmann's bundle. Question 5. What is the name of this section in the septum of the heart that branches off the atrioventricular node? This is the bundle of His. Question 6. What is the name for this electrical wiring that takes the signal to the left ventricle? Hopefully a nice easy one. This is the left bundle. Okay, let's look at different parts of the ECG. What's this? Question 7 is, what's this first bump on the ECG? This is the P wave. Question 8 is, what is this this part of the ECG in the middle? This is the QRS complex. Question 9. What's this final bump on the ECG? This is the T wave. And question 10. What is this flat part of the ECG? This is called the baseline. Question 11. What does the P wave on an ECG represent? It represents atrial depolarization and contraction of the atria. Question 12. What does the QRS complex represent? It represents ventricular depolarization and contraction of the ventricles. Question 13. What does the T wave represent? Ventricular repolarization. So it's kind of resetting of the ventricles. Okay, onto a case. This is a 68-year-old man who presents with palpitations. So he says his heart feels a bit funny. On examination, he has an irregular pulse, and he has a history of high blood pressure. Question 1. What's your suspected diagnosis? Diagnosis that you suspect with an irregular pulse is atrial fibrillation. And this is where you have disorganized electrical activity in the atria. And so the atria just kind of chaotically fibrillating. The electrical activity is very chaotic and disorganized. Intermittently or sporadically, these signals will pass through the atrioventricular node to the ventricles, and this causes an irregular ventricular contractions. Usually there's a fast heart rate with a ventricular rate above 100 beats per minute. Question 2. What are the key ECG findings in this condition? So there are 3 key findings. The first is absent P waves. So there's no P waves on the ECG because those atria are just completely chaotic. The second thing is you often get a tachycardia but specifically a narrow complex tachycardia, meaning the QRS complexes are narrow as opposed to broad, and narrow is normal, and tachycardia refers to a fast ventricular rate. And the third finding is an irregularly irregular ventricular rhythm. So these are QRS complexes that are occurring at random intervals. So they're not regular, they're just completely random. The third question is, what's the first line medication to control the heart rate? The first line is beta blockers, for example, bisoprolol. Now, if you imagine that the atria at the top are contracting completely randomly, they're not really functioning at all, and the purpose of the atria is to fill the ventricles with enough blood that when the ventricles squeeze, they pump lots of blood out of the heart. The problem with the atria contracting randomly is that the ventricles need to fill with suction and gravity rather than in a healthy heart, the ventricles are filling by the atria actually pumping blood. In atrial fibrillation, the atria aren't really pumping, so they need suction and gravity. But this reduces the efficiency of the ventricles filling, meaning that the ventricles need longer to fill with blood. When the heart rate is too fast, there's not enough time between ventricular contractions for them to properly fill with blood. So bisoprolol or beta blockers are used for rate control to slow the heart rate under 100 beats per minute, and this gives more time between ventricular contractions so that suction and gravity can fill the ventricles with blood, and this improves the cardiac output. Question 4. What treatment is used to reduce the risk of stroke in atrial fibrillation? Long-term anticoagulation, which reduces how fast the blood clots. Usually this is with a direct-acting oral anticoagulant, or DOAC, for example, apixaban, rivaroxaban, edoxaban, and dabigatran. These are all examples. When you've got atrial fibrillation, because of this atria just contracting completely sporadically or not really functioning at all, blood can collect in the atria, particularly the left atrial appendage, and then form a blood clot. Then this blood clot can come out of the atria into the ventricles, up through the carotid arteries to the brain, and cause a stroke. So anticoagulation reduces thrombus formation and reduces the risk of stroke in patients with atrial fibrillation. Question 5. What risk assessment tool would you use to calculate the risk of stroke to decide on whether to give a patient anticoagulation in atrial fibrillation? You would use the CHADS-VASc score. And this is essentially a mnemonic. And if you have any of those features, it scores you 1 point for each feature that you have. So if a patient scores 0, they have none of the features, they don't need anticoagulation. If they score 1, the recommendation is to consider giving them anticoagulation in men, but women will automatically score 1. And if they score 2 or more, then it's recommended that they have anticoagulation. Just a quick reminder, if you're making your own notes from this video, I would highly recommend instead just downloading the notes. Save yourself a bunch of time. They're really nice, and you can use them to test yourself over and over again, along with the answers and explanations and illustrations. Much better than making your own notes. Just head over to the link in the description. You will need a Patreon membership, but that gives you access to the member site where you can also use short answer questions, multiple choice questions, extended matching questions, flashcards and everything that you can use to even further test your knowledge. So tons and tons of value on the member site. You can use it pretty much for all your medical school revision. That's what I highly recommend as opposed to making your own set of notes. Okay, on to the next case. Next case is a 25-year-old woman, and she presents to A&E with sudden onset palpitations. She feels like her heart is really racing, happened all of a sudden, and she doesn't know why. She has a regular heart rate of 180 beats per minute, and this is what her ECG looks like. Question 1 is, what's your diagnosis here? The diagnosis here is supraventricular tachycardia, which refers to a fast heart rate originating above the ventricles. And it's caused by the electrical signal re-entering the atria from the ventricles. And this could be back through the atrioventricular node, or it could be through an accessory pathway that leads, like an extra electrical pathway, leading from the ventricles to the atria. So what happens is the signal comes from the atria down to the ventricles, then back to the atria, then back to the ventricles, and it creates this self-perpetuating loop, which doesn't have an endpoint and just keeps causing a very fast heart rate. Question 2. What is the normal QRS complex duration? The normal duration of the QRS complex is less than 0.12 seconds, or 3 small squares. So if you've got a patient with tachycardia, you split them into 2 groups. One is narrow complex tachycardia, where the QRS complex duration is less than 0.12 seconds. And then you have broad complex tachycardia, where the QRS complex is more than 0.12 seconds. And supraventricular tachycardia typically falls into the narrow complex tachycardia group. Question 3. What is the first-line acute management for this condition? This is not a medical management. What would you do immediately when you saw this patient? The answer is vagal maneuvers. And the idea is to stimulate the vagus nerve, which causes the heart rate to slow down. And the way you can do this, 2 main things. One is the Valsalva maneuver, which increases the intrathoracic pressure, so the pressure inside the chest, and stimulates the vagus nerve. One way to do this is get them to blow into a syringe. Second thing is carotid sinus massage, which is stimulating by rubbing the carotid sinus in the neck, stimulating the baroreceptors in the carotid sinus, which again stimulates the vagus nerve. Question 4. What's the first-line medicine for acute treatment of this condition? The first line is adenosine, and this is given by an IV rapid bolus IV injection into a large proximal cannula, so often in the antecubital fossa. Adenosine works by slowing cardiac conduction primarily through the atrioventricular node. So it slows how fast the electrical signal passes through the AV node. It interrupts the AV node or the accessory pathway in the supraventricular tachycardia, and it kind of resets the patient back to sinus rhythm. The half-life of adenosine is less than 10 seconds, so it only works for a very short time, which is why it needs to be given as a very rapid bolus into a large cannula, so it gets to the heart sort of nice and fast and hard to have the effect. The doses, you give the first dose, hopefully it works. If it works, great, but then you might need to give further doses, and the doses are increased until you achieve sinus rhythm. So the doses are to start with 6 milligrams for the first dose, then try 12 milligrams, and then try 18 milligrams. Question 5. What's the definitive treatment for recurrent episodes of supraventricular tachycardia? The definitive treatment is radiofrequency ablation. So what does this mean? Well, a catheter is inserted via the femoral vein, and it's fed up into the right atrium, and then they look using the catheter for any abnormal electrical pathways that might be causing the SVT. And then when they find the abnormal pathway, they use radiofrequency ablation to kind of burn that pathway and destroy it, turn it into scar tissue. And by removing that abnormal pathway, that should hopefully stop the episodes of SVT. On to the next case. The next case is an 83-year-old man who presents with fatigue and episodes of dizziness. His heart rate is 46 beats per minute when you check it. Question 1 is, what's the diagnosis based on the following ECG? This ECG shows first-degree heart block, and this is caused by delayed conduction through the atrioventricular node. What you can see on the ECG is a prolonged PR interval of more than 0.2 seconds. All the P waves are followed by QRS complexes. Question 2. What's the diagnosis based on this ECG? This ECG shows complete heart block, which is also known as third-degree heart block. And you can see there's just no relationship between the P waves and the QRS complexes. They're all just completely separated from each other. Question 3. What's the diagnosis based on this ECG? This ECG shows Mobitz type 2, which is a type of second-degree heart block. And what you can see with Mobitz type 2 is intermittent failure of conduction through the atrioventricular node. So occasionally there's a missing QRS complex. Basically, it looks like sinus rhythm, but then occasionally you get a missing QRS complex following a P wave, so a P wave on its own. Question 4. What's the diagnosis based on this ECG? This ECG shows Mobitz type 1, which is again a type of second-degree heart block, and is also known as Wenckebach phenomena. So here you can see this is caused by conduction through the atrioventricular node, taking progressively longer until it fails. What this looks like on an ECG is the PR interval, which is the distance between the P wave and the QRS complex, increases over successive sort of QRS complexes until a P wave is not followed by a QRS complex. So it's a gradually increasing PR interval then a missing QRS complex. After the missing QRS complex, the PR interval resets back to baseline and the cycle repeats itself. The next question, or the next case, is a 36-year-old man who takes quetiapine for schizophrenia, and he attends for a routine ECG. And this is what his ECG shows. Question 1. What is the key finding here on the ECG? You can see a prolonged QT interval. So the QT interval is from the start of the QRS complex until the end of the T wave. And what we call the corrected QT interval, or the QTC, is an estimate of the QT interval if the heart rate were 60 beats per minute. So the QTC is a bit more kind of accurate and useful. Antipsychotic medications can prolong the QT interval. And another common cause is electrolyte imbalances. Question 2 is, what's the cutoff? What duration is the cutoff for diagnosing prolonged QT interval? We usually base this on the corrected QT interval, and if it's prolonged at more than 440 milliseconds in men and 460 milliseconds in women. So women are allowed a slightly longer QT interval. Question 3. What arrhythmia is associated with a prolonged QT interval? So in patients with a prolonged QT interval, you'd worry about Torsades de Pointes. And this is a type of polymorphic ventricular tachycardia, where the ventricles are just beating really fast. It translates from French as twisting of the tips. So on an ECG, you can see that the size of the wave gets gradually larger, smaller, as though it's twisting around the baseline. This may progress to ventricular tachycardia and cardiac arrest. So it's a bit of a risky ECG. So this is the main risk with a prolonged QT interval. Question 4. What is the treatment for this Torsades de Pointes? Is treated with a magnesium infusion, even in patients who have a normal magnesium level. And question 5, what are the shockable cardiac arrest rhythms? So if someone's in cardiac arrest, you check their heart trace, what rhythms would be shockable and where you'd give a defibrillator shock? This is worth remembering. So one is ventricular tachycardia and the other is ventricular fibrillation. These two rhythms are shockable rhythms. The non-shockable rhythms, where a patient is in cardiac arrest, their heart has stopped, you can't feel a pulse, the rhythms you wouldn't shock, there's two again. One is called pulseless electrical activity. This basically means the patient has a pulse and there's electrical activity on the ECG, but it's not ventricular fibrillation or ventricular tachycardia. This is called pulseless electrical activity, and it's not shockable. The other one is asystole, where there's no trace on the ECG. Well done. That's the end of the video. Well done for getting to the end of the video. If you enjoyed this video and you like this kind of content, really consider signing up to the Zero to Finals Ultimate Revision course, which is just perfect for your medical school finals. I also run Zero to AKT GP courses. The Ultimate Revision course for medical school finals, I've got some coming up in October, November, and early December. Going to be in Manchester, Birmingham, Norwich, and hopefully in London as well. You can get tickets to those now. Just head over to zerotofinals.com/medical school finals. There's a link in the description. Use the link in the description to download these notes. And the next thing I'd suggest you do since we've been through the whole of cardiology, I'd recommend heading over to the members site at members.zerotofinals.com and testing your cardiology knowledge now using the short answer questions, multiple choice questions, flashcards, or extended matching questions. See how much you retained from this video. And testing yourself is going to help you retain that information long term. The other thing you can do, make a note in your diary, come back and watch this same video again in a month's time and see how much you remembered. I will be uploading the core content for cardiology video similar to this, and then the advanced one in due course. I've already got the notes, but I just need to record the video. And so I'll catch you in the next video. Well done, and see you soon.